be the revenue cycle presentation.
There we go. Beautiful.
Okay, that was weird. So anyway, revenue cycle management is kind of a marketing term that's out there. We didn't really start using revenue cycle management until about 2 or 3 years ago. It's always billing, and the billing is basically 13 different functions of the billing process. And revenue cycle management is more of the billing service company. So you have billing applications, and you got revenue cycle management, which is really outsourcing the billing to someone else. Well, I kind of talk about the differences between the two, but it's been an interesting thing that's been happening the last couple of years with all the different changes. And now the arrow key doesn't work again. All right, something's wrong with this whole presentation, I think. I'm gonna try something again. Share it. Point now.
Yes, we're good.
Okay. Yeah. So one of the things interesting is going on is over time, the employment market of the healthcare industry keeps growing. You look at how many people are doing it, where the regular other industries, during COVID, the number of employment really went down. We're getting back up to the normal level, but healthcare has been a busy process no matter what. Even though during COVID, we had a lot of issues out there, we were still hiring people and still growing tremendously. Healthcare is interesting because we're not really a healthcare industry. We're a medical reimbursement industry. There's really not big incentives to keep people healthy. So we're really a medical reimbursement system, not a healthcare system. And we're going to talk a little bit about that later on, about how we really need to move to a healthcare system. And that affects how you do revenue cycle. When you look at overall spending in healthcare, it keeps going up about 5.8% every single year. It's going to continue to grow at that same rate. Healthcare is a growing industry. There is nothing going to slow it down, especially with the elderly. The older people are now getting, more people on Medicare. The older you are, the more healthcare costs we have. There's a direct relationship in healthcare costs and age. So as the population gets older, we're going to spend more money on it. Again, we can't keep doing all this. We got to find a way of changing the healthcare reimbursement model. The other part about healthcare is that there really is very little tolerance for things that don't work. You look at healthcare executives, they have basically about 80% of them want no risk on any of their kind of projects they're doing. I want things to work. Guaranteed it's going to work for me. There's very few people who are willing to take risks today. So you got to think about that if you're trying to work with provider organizations or if you're a vendor that's out there. I want to have a solution that's going to work. I don't want to care about anything else. I don't want any kind of issues that are going to pop up. So remember, it's all about ensuring everything's going to work effectively. And when you start looking at the outsourcing industry, it is still growing tremendously. More and more providers are looking at outsourcing their services. And what that basically means is I'm a doctor's office. I'm going to let somebody else do the billing and the collecting for me. It is so hard today to hire people that to work in a doctor's office or even the hospital. People don't want to work as much anymore. It's a lot of hassle to actually go through and collect from insurance companies and then from the patients. So more and more organizations are considering outsourcing. I've got a 58 hospital system that decided to outsource everything to an outside group because they can hire people, they can pay them better, and less hassle for me, as long as they're guaranteeing that I'm going to get a good return. That's the big thing. I want to have a good return on my investment. So you start looking at the percentage breakdown from 2007 to 2022, you see that internal billing has dropped down to about 30% now. And this is for hospitals and doctors. Billing companies are starting to increase a little bit. Interesting part is the software vendors have gotten into the billing. So companies like eClinicalWorks, NextGen, Greenway, some of the other physician practices, and then of course Cerner had a revenue cycle service offering for a while. They sold that off to R1, but R1 now is kind of the dominant player in a lot of the RCM outsourcing services. So again, inpatients coming down as far as internal, and more is being outsourced to somebody else that has the expertise to hire to actually do the actual reimbursement and collecting better money. So what's the typical cost for this? Have somebody do your billing, they're going to charge 6 to 8%. But why change? I mean, it's working now for you well. You kind of lose control. I really don't have a problem today. But the bottom line is companies like Athena Health came out and said, look, we guarantee you'll make more money with it. And it works. They guarantee, in a lot of cases, you're going to make 7% more money if you outsource to them. Well, how can they guarantee something like that? Well, their tools they have and the service people they have are very good. They're to the top of the industry. And they make sure that you're going to collect more money. And if you don't collect more money, you don't have to pay as much. So again, they guarantee That seems to work. I want to guarantee that I'm going to make more money if I switch over to you. Companies out there have to come up with that kind of model. And if you're a doctor's office or a hospital system, you want the vendor to guarantee they're going to make you more money, or why outsource it? So right now, RCM billing companies have about 200,000 physician out there, providers out there. They have about 1,200 hospitals, so it's not as big a percentage. But again, as I mentioned, they charge between 6 and 8%. The interesting part is 48% of all these billing companies also offer an EHR with their product. Everybody wants integrated products today. And if a billing company is not offering an EHR product, they may not last in there for much longer. I have to have something that can really handle, I would call it the one throat to choke. One person to talk to that handles my EHR, my billing software, and my collections work. I want somebody who does all of that. And over time, we're seeing, I said, the vendors that are also getting involved in this, where their costs are a little bit less. I sell the software and the services. I collect for you. And they're actually charging less money today. But again, the object is to find a way of, this is important, reducing your revenue leakage. How much money are you losing because things are not being done effectively? Denial management, claims that get denied, claims that you miss the timely filing requirements that are out there, underpayments that are going on out there. All those issues take money away from an organization. You want to be able to reduce that revenue leakage as much as you can. And nationwide, it's about 11% of all payments are not paid because of revenue leakage, things that we're not doing correctly. And we want to find an organization that can help us clean that up and get that revenue leakage down to that 1 or 2%. You'll never get everything down. There's a lot of things you can do to make sure that you get paid for the services you've done. And it really gets down to these kind of components. Eligibility determination. If a patient's not eligible for services today, you really can't bill for it. That's revenue leakage. Authorization processing. You have to get pre-authorization for certain things. If you don't get the authorization done, you're going to have revenue leakage. You're not going to get paid for it. Patient comes in to see a doctor. We decide to do an x-ray. Are they going to cover that or not? You have to make sure you're collecting that money, that authorization up front. Co-pays are pretty easy for most people, but I see a lot of organizations, the patient comes in, oh, I don't have my credit card today. I don't have my checking account with me today. I can't pay the copay. You got to collect that copay up front. You got to make sure you get it. And I try to collect before they even show up in the office. There's a lot of new technologies out there that help collect the copay before the patient even comes in. That's what I have on my doctors. They all have, pre-collection copays for that. That's revenue leakage. Coding. Are you coding effectively? Are you coding the right way? Most of the doctors today are used to the old way. You basically pick the code, but today a lot of the coding is based on how much time you spend with the patient. So it's time-based coding. People are not really figuring that out yet. That's revenue leakage. Think about bill submission. Are you actually sending the claims out correctly? If your clean claim rate is not above 95%, which means the claim is coming out of your computer system, going to the clearinghouse and going right to the payer, and the payer accepts the claim, you've got problems. Some organizations run 98.5% clean claim rate. That's what we need to really look at. How do I make sure my claims are going out clean, where I don't have to touch the claim? If I have to touch the claim, there's going to be delay in payment. It's also going to be revenue leakage. And it goes all the way through the list. I'm not going to go through all of these, but denial management is probably the biggest one. The problem with denial management is most of the software products will tell you you've had 50 denials today. But why? Well, I can look at each denial one by one and find out. I need a true denial management software product that analyzes all my denials and comes up with a solution. How can I eliminate the denials? Don't tell me I had a denial and how to fix the denial. Tell me how I can eliminate denials occurring. If I'm not checking eligibility up front, or I find out that the doctor's NPI number is wrong in the computer system, don't fix each claim that got rejected. Fix the original problem. That solves a lot of problems. Again, you follow these kind of things, you can get from a 9 to 10% revenue leakage rate to a 1 or 2%. But you got to look at each one of these factors. It's very important. And I won't go through all this because there's going to be a webinar. People can actually go back and look at this. But again, it's all about electronic claims going out. You got a clearinghouse. You're routing all the information. Is your clearinghouse doing the right upfront edits? Is your software doing the right front edits? A lot of the software got installed a couple of years ago and it was editing for that year. But are you getting the billing edits updated every single year? I've got practices that are sending out diagnostic codes that don't even exist, CPT codes that don't exist, or CPT codes that don't match the diagnostic code, and they keep getting denied. Why? Because their database is not getting updated. Make sure your database gets updated with all the business rules. It's very important to have that. And again, there's a lot of different things to look at, but you got to make sure the claim goes out clean, the payer receives the claim, and they pay the claim in a timely manner. If you have issues with that, you're going to have delays in payments and you're going to have revenue leakage. And like I said, I'm not going to go through each one of these, but once you get the claim through, there's a lot of times there's a secondary claim. You have to make sure you update that secondary claim with whatever the payment was the first time. And once you go through the primary, you got to the secondary, maybe there's a tertiary, mostly it's primary and secondary today. What do you do with the patient? We have to come up with new technologies that help us figure out what the patient's going to owe prior to the patient being seen by the doctor. That's coming up with an estimating system based on this patient and their deductible amount and their insurance company. What is the insurance company going to approve and what are they going to pay? For example, I've got a patient coming in, it's a $100 charge, and the healthcare plan approves $80. So the balance is $80, you have to write off $20. The patient has a $500 copay. That means that whole $80 is dependent on the patient to pay that bill. We need to be able to figure that up right up front, collect the $80 up front from the patient, and not worry about any additional billing for the patient. And it basically, when the insurance company pays their portion, it zeroes out the claim. We got to get away from working all these claims because we don't know what the insurance company is going to pay. I need a good estimator system that tells me, based on this patient, based on the deductible today, what portion of the patient is going to have to pay, and get it to a point where we're actually automatically writing off these things to what the category ends up being. Instead of waiting for the insurance company to adjudicate the claim in 3 or 4 months, we got to figure it out right up front, collect the money from the patient. Patient statements are a big issue. More organizations are moving towards electronic payments, but I find the doctor's offices, there's still about 92% of them are still sending out paper bills. Why? I mean, almost everything's done electronically today. Why don't you have a system where they can pay their bill online? I can view my bill online. I can pay my bill online. Companies like Epic do that today with all their hospitals and all their doctors. I can pay my bill online right away. Usually I pay my bill before I've even seen by the doctor. So we got to get all the other practices out there in the hospitals to have a way of being able to pay their bill, the patient bills online. I wish you could get the insurance companies just to pay it online much more easily, but you still got to go through the billing process with them. But the patients, you should be able to pay that bill online and hopefully be able to remember that credit card number. If I have the credit card number in there, it makes it a lot easier for me to actually pay my bill. And you start looking at what kind of things can go happen out there. You know, what are the accelerators to overcome a lot of these issues? There's a lot of things we can do, but basically it's re-engineering the whole billing process, making sure you've got, revenue leakage taken care of. What is your overall average on certain things? What is your average denial rate? What is your clean claim rate? What percentage of your patients you're checking eligibility for? There's about 17 indicators. I call them key performance indicators you should be tracking to know how well you're performing compared to your peers. If your denial rate is above 6%, that's probably too high. I have a lot of practices that are running 19 to 20% of all the claims get denied, and they work them each month. Why don't you eliminate the denials by finding what the problem is and going back and fixing the problem? Yes, you got to fix the claim. If I fix the problem, that eliminates a lot of those denials. But you got to walk through each one of these steps and find what is the best way to do it. What's the most cost-effective way of improving the overall reimbursement? By using an outside firm or even your internal firm, let's make sure the revenue cycle process, again, it's a marketing term, it's a process, is working effectively. One of the big problems we have a lot of times is the overall high cost of staff today. Prior to 2020, when COVID kind of came in, we could have actually paid people $12 an hour to work on billing. Nowadays, it's $18 to $25 an hour. You're talking about a 40% increase in cost just to get the bill paid today, because a lot of people don't want to work anymore. They like staying at home. Can your office staff, like a billing staff, actually work outside of the office? Of course they can. So look at those kind of things. You have to look at different ways of getting the people to actually work. Again, I've got a lot of organizations that are short 40% of their staff they're not coming to work anymore. How can you run a practice if you're missing 40% of your staff? You have to pay more or give them different benefits like working from home. But again, you also want to get to a point of you don't want to have to keep retraining people. I've got a practice that has about 2 new people in every single month because the staff only stays 2 or 3 months. Then I got to retrain them. Again, the software product does a lot of the work for you, but again, they have to understand your policies, your processes, your policies that you follow. They may have to learn a different software product because they may not have used that same software in the past. So you got to find a way of handling all that and basically reducing errors. 8 to 12% of all your revenue is lost because there's an error being made. We need to find out what that error is and correct it so it doesn't occur. Yes, you got to keep saying, fix the problem, that one claim, but fix the real problem, the source of the problem. So you start eliminating a lot of these denials or claims that don't go through. Again, it's very complex out there. Medicare, Medicaid have their rules. Obamacare Marketplace has their rules. All the insurance companies have their different rules. Basically, there's a lot of rules you have to follow. And it's very hard to keep up on all the rules and very hard to train your staff on all new rules that come through. And these rules can change every year by different healthcare plans. There's a lot of different things you have to think about. So you really have to look at all this revenue cycles, your front end and your back end system. What are you doing to actually capture the right information at the right time on the right place? Is the patient giving you the right information? Half the time, the patient says, I'm on Medicare. Yeah, they're really on an Advantage plan through United Healthcare. And how are the staff picking that insurance plan? Are they picking United Healthcare? Are they picking Medicare? Are they picking Medicare Advantage through United Healthcare? It makes a big difference because the software is going to basically help you figure out how to collect. If you're selecting the wrong insurance company, you're not going to get paid because everything is sent through that insurance company profile name. So you have to make sure they're doing all that right. Collect the money up front. Ensure that everything is done correctly. We find that a lot of the claims get rejected because somebody in the front office did not do their job effectively. So you got to worry about that. But obviously, the big portion is the back end. You've got the claim generated. It's been sent off. It's been sitting there for 30 days, 60 days, 90 days. How often does somebody go in and actually touch the claims to check on, see what the status is? The rule of thumb is usually every 30 days, you should check every single claim if it's still outstanding to find out what the status is. But maybe that should be every 15 days now because everything is pretty much automated today. But if the insurance company hasn't paid within 15 days, you should be contacting them. It's now been 30 days, you follow up with them. Now it's been 45 days or 60 days, you have a system that actually keeps tracking different things and telling the billing people or the follow-up staff what they need to be checking and which claims need to be checking next. It's important to follow through on all that. Because again, if you're not following through, you're not going to get paid. The healthcare plans make money off of not paying for claims. So that's their goal. I'm not going to pay for the claim. I want to find a way of denying that claim, saying I never got the claim. It's up to you to make sure that you've got information and knowledge to say, this is what I've done. I've contacted you 3 times. You responded this way. So it's kind of a tracking system that says I am now tracking this claim effectively every 15 days. Some practices don't do it at all. They just wait for a patient to pay the bill. If you're going to succeed in this business, you got to check that to make sure you're collecting that money. And every 15 days is a good way of doing it. As I mentioned, there's a whole bunch of differentiators out there. If you're a billing company, you really got to explain what makes you different. If you're a doctor's office, you got to explain to the billing company what makes you different. Because the difference is what really sells, and difference is what really makes you money or lose money. A lot of different things you can be looking at as far as tracking everything that's going on. So a poll just popped up here in front of me.
Yeah, I didn't want to interrupt your flow, but I was just gauging the audience to see what type of attendees we have here while you're talking.
Yeah. Okay.
I'm going to take it off in a second.
There we go. That's good. Yeah, it kind of popped up right in the middle of my screen. So again,
Sorry
if you're a vendor trying to do this, you really have to have a go-to-market strategy that tells you I'm better than everybody else. Again, Athena Health's approach, we guarantee you'll make more money, 7%. Other vendors, well, I'll do my best job I can, and I'll try to collect money from you. Who are you going to buy from? Somebody who guarantees a 7% improvement, or somebody that's going to try their best? A lot of these are small companies that in your area, mom and pop type things. How do you know you're getting the best performance? It goes back to that 17 key performance indicators. Let's track how you're doing today and how well you're doing in the future if you change companies. And ask the vendors, what are their key performance indicators and how well do they track it? Another session, we'll talk about what the 17 key performance indicators are. You need to know how you rank compared to your peers out there today. I guess when you did that, there it is. I said the screen was not moving again. On the back end side, we talk about what the problems are. It's denial management. If a claim gets denied, that means they don't have to pay it. And now you can, go back in and follow up on that claim, ask for an appeal on the claim. But if it's been like 45 days, they deny the claim. Now you're going to try to refile it and redo things. I've seen a lot of times where the billing company just refiles it. It got denied the first time, let's refile it. What does that do? You didn't fix it. It got denied for a reason. There's 503 different denial reasons. Research those reasons, understand why it is. Don't just resubmit it, because all you're going to do is get it denied again. Denials need to be tracked. And if I got a claim denied, I need to follow up on a timely manner, because that timely filing goes away. They're saying I did not get the claim. It's got denied. That means I never got the claim. It's not even in my database anymore. You got to follow up on those things, and follow up obviously on anything that's over 120 days. There should be no claim over 120 days, except for what we call liability claims. Auto accidents, personal injuries, workman's comp claims. Sometimes they're not paid for 3 months to a year, sometimes even longer. But your regular commercial accounts are going to be paid within 30 days. There's a lot of different rules around that today. So nothing should be over 30 days old. You need to find out if any claim is over 30 days old, you got to find out why, because nothing should be over 30 days anymore. So you have to think about all this in your whole process. What processes can really improve the bottom line? What can you do in your revenue cycle process? Is it better front end? Is it checking eligibility better? Is it tracking the denials? Again, you should be running a 98% clean claim rate. You should be running a less than 6% denial rate. Your days in AR should be less than 25. There's a lot of different indicators like that, but find out what the issues are. What processes can really improve customer relations? Remember, you got to collect money from the patient too, and from the insurance company. What can you do to make it easier for that patient to interact with you? Patients want to see a copy of their bill. Make it easy for them to pull up. Do it online. I want to pay my bill online. Allow them to do that. And figure out what processes really work out there. And again, what can you implement in the next 3 to 6 months that's going to improve your bottom line? It's going to improve additional 5 or 10% in income coming in. Don't come up with projects that are going to be 2 or 3 years to get implemented. What can you do today that's going to improve your bottom line? And again, make sure if you're implementing something so that's really going to improve the bottom line, not what somebody thinks it might do. It's the actual theory. I want to see it in real practice. And then really kind of focus on the issues. The front end, as I mentioned already, registration quality. Are they collecting the right information? Point of service collections. You got to collect that money, the upfront money. Verifying insurance. How well is your team verifying that insurance? That patient really has that insurance. You got a lot of third-party resources out there you can work with. But as I always say, really emphasize that denial management. That can be 20, 25% of all your money goes out the door because the claim got denied. That's where you really start a lot of times. Work on denial management, find out why claims got denied, and then fix the problem. Yes, fix the claim and fix the original problem. There's a whole bunch of things about, timely filing issues, underpayments, a lot of things to work on, but make sure the claims go out clean, make sure denial rate is low, and come up with a better system for helping the patient pay their bill online. That's what's important. You do all those kind of things, you're going to get a much better revenue stream coming in. So before I kind of leave, it's basically, is there any questions today out there? Or Michael, you might have any questions. And then hopefully we'll be able to get to your presentation now that kind of goes over a lot of other things.
Yeah, we don't have any as of yet in the Q&A, but everybody watching currently in a live setting, feel free to go ahead and put a question in the Q&A.
I think on our next session, basically we'll have a session on the 17 key performance indicators, showing what they are and showing, how do you measure yourself to that? We'll show the actual calculation and the actual key performance indicators and show the benchmarks. I have a document that actually shows 80th percentile, 50th percentile, 20th percentile, and really figure out where you are. And it really creates a model for you to find out how well you're doing. I have it for hospitals and for doctors. So we'll use that in the next session.
Excellent. All right. Yeah, we still don't have any questions as of yet, but in the replay we might. So feel free to reach out to either of us as those questions may come up. I'm going to go ahead and just jump in and get started.
Yep.
All right. Can you see my screen?
Yes, I can see it.
All right. So let's go ahead and jump in on the topics to discuss. We're going to just briefly broach the topics of disruption. What is the word disruption? It used to be when I was growing up that disruption was a bad thing. You get sent to the corner of the classroom, in a little timeout when you disrupt. But these days, it's not as much a bad thing. It's actually a good thing. And we'll explain why. Talk about the cloud computing evolution. Value-based reimbursement will just lightly broach, but it's probably worthy of a separate webinar in itself at some point. the question of who owns your patient data, and we've already discussed the revenue cycle management component, thanks to Mark's excellent presentation. So what is disruption? Go ahead and jump right into it here. To be a disruptor is to create a product, service, or way of doing things which displaces the existing market leaders and eventually replaces them at the helm of the sector. Disruptors are excuse me, let me move this to the side so this doesn't interrupt. There we go. Disruptors are generally entrepreneurs, outsiders, and idealists rather than industry insiders or market specialists. Disruptors are often linked to the fast-moving technology industry, but can be found in almost any area of business. So if you glance at Wikipedia, Wikipedia explains disruptive innovation as being a forward-looking approach to being a positive change maker. A lot of companies that have entered the healthcare space with the SaaS or cloud computing revolution have been able to really take technology to a whole nother level in offering patient care. Things like chronic care management software. We saw what telehealth did during COVID. I know that right now there's a lot of debate going on at a government level where they're rolling back some of the stuff that was in place for the last few years. But nonetheless, the fact that telehealth existed when we were hit with such an untimely national or international worldwide crisis goes to show you how helpful technology can be. We live in a big country and a lot of people live in rural areas. Mark, you could speak to that, you know, being from Texas. People can't necessarily just get to the doctor at the drop of a dime. And the fact that that was available was great. Let's move into talking a little bit about what cloud computing is, because I know that I say this all the time, but there are vendors out there that are trying to market their products as being cloud-based when they're really not cloud-based. So, for instance, vendors, when you hear things like our product needs Microsoft Internet Explorer to work or doesn't work on Chrome, okay, that should just raise a flag in your head because, you know, Internet Explorer for the most part has been replaced. Even Microsoft themselves, by the way, have released a new browser called Edge. I don't know if you know this or not, but Edge is essentially Google Chrome. It's just a white labeled privatized version of it that Microsoft entered into contract with Google on, whereby Microsoft leadership realized and they bit the bullet and accepted the fact that, listen, we are not the best people out there making browsers. Just the reality is Google seems to, you know, have an edge on it. So let's partner with them and use their browser. We'll have a privatized version of it called Edge, which is what you probably see in Windows 10 or Windows 11. And Edge is really Google Chrome, but just built for Microsoft. True cloud computing products are built on modern frameworks that have very flexible user interfaces like HTML5 and working Chrome-based browsers. And we talked about, you know, cloud computing really coming down to like Amazon AWS, Google Cloud, Microsoft Azure, and so on. The big question that's come up since the last webinar, I've spoke with practices that ask, what if my software is not built as a true SaaS solution and I'm happy with it? You know, I'm not looking to change. You know, and that's a good question because the reality is there are a lot of groups out there that are just happy with what they're using, it's working, and they're not looking to change, at least at this point in time. So what I wanted to contribute on this piece is that internet speeds have evolved considerably, such that you can have the server that serves your client server software in your office hosted elsewhere, like in a tier 1 hosting facility. And the internet is fast enough where you wouldn't even notice any sort of speed difference. Why do that? Simple. I've heard countless stories of something unexpected occurring and wiping out years of patient data and patient records. For instance, natural disasters, Katrina as horrible of an event it was a wake-up call to a lot of people in the healthcare space many years ago, because, you know, overnight, all of this patient data was just gone, you know, because they had a server in their office that wasn't being backed up properly. And just like that, you know, everything was just disappeared. So having a professionally hosted server offers what I like to call peace of mind, which is really a priceless commodity, by enabling 99.999% uptime guaranteed, and daily or even hourly live professional managed backups. So, you know, in a true hosted scenario, when a hardware failure happens, you don't even know about it because they have staff on site in the server room that are aware of something happening before it happens. They're like basically doctors, you know, for patients, being the servers, and they're able to do surgery by replacing the component before you know something even was wrong. And I was just going to make a comment about how EMR Consultants is offering, you know, either virtual servers or dedicated servers. And as a summer special, if you use the coupon code disruption, you get a 15% discount on any orders over $50 through Labor Day. Interoperability. Let's just briefly talk about what that is. The word interoperability generally means portability, being able to port your patient data from one provider or one health system, one healthcare facility to another, to democratize patients' data, to offer patients data to be easily shared with other systems without losing clinical discrete data status. And finally, we really reached a point in the EMR space where we've really gotten past that hurdle that we saw over the last, you know, 15 years, where vendors were being very agnostic about how they handled sharing data and private about it, because they didn't want to make it easy for people to switch systems. But we've evolved past that, thankfully. And you know, that started with things like meaningful use, but it's gotten to a point where we like seeing this disruptive evolution continue, and to see the strong products, like for instance, the ones that offer RCM, like Mark talked about, we like to see those succeed. Let's talk about migrations for those out there watching this that are thinking, maybe I need to reconsider what system I'm using, because you know, it's hard to reach the folks that I used to be able to reach at the company that's serving my software to me. That, you know, maybe they're offering email support only. There's nobody there to answer the phones, or whatever the case is. You know, I'm not able to customize the system to work for me, or it's not meaningful use, you know, ready, or they're not staying up at the latest standards. So switching EMR systems is a necessity for many, and it's actually very doable. We can talk offline if anybody watching this or here has an interest in how we can move your data from one system to another. One thing you'll know is that I'm never pushing anybody, and I don't think Mark either pushes anybody to a specific system, because we have no other ulterior motives in play other than what's in your best interest. We're not, you know, out there as consultants selling software. We're out there serving the needs of those who need their needs served. Value-based reimbursement, real quick. What is value-based care? What is value-based reimbursement? Value-based reimbursement is changing the underlying economics of healthcare by changing reimbursements of how healthcare providers are being reimbursed. We're moving from providers being reimbursed from based on time and documentation to being based on value. And naturally, when you think about that, what does that mean? It means that if I'm taking better care of my chronic care patients over time than really any other doctor in my vicinity, I'm going to get paid better, because that's really what it comes down to, is how the patients with chronic conditions can manage those conditions over time under my guidance as a physician. So insurance companies have proved, and this is not news to anybody, they have some of the smartest people with these insurance companies that are risk, you know, adverse, you know, risk experts, people that can run simulations and understand from their population they're serving what could go wrong financially, medically, and so on and so forth. And they've come to the conclusion that with overwhelming support that by reimbursing there's over time for doing a better job in caring for their patients will actually save them money in the long run. So it's really a win-win situation where you have patients that are getting the better care and are actually healthier. And believe it or not, insurance companies are paying less out of their pocket for the care. It's the chronic care patients that aren't taking care of themselves that are the most costly, they've learned. In fact, Mark explained to me as we were prepping for this, making sure that nothing would go wrong, by the way, but of course, unfortunately for those who are here in the beginning, we apologize, but he educated me on the fact that healthy patients cost 18% less over time. They've come to that conclusion, which is fascinating. That's a big number when you think about the costs involved in healthcare. For a payer, imagine an insurance payer saving 18% on the lifetime of patient care. That's a lot of money. And guess what? The patient's healthy at the end of that time. So that's, in my opinion, a win-win. And in summary, value-based care is really all about healthcare being in the business of keeping people healthy, and it starts with being proactive rather than reactive. Question of the day. Mark and I were having a little debate as we were prepping. The famous question of who owns a patient's data. Mark, you want to chime in and talk about this for a sec? I think you're on mute still.
Yeah, I was on mute there. Yeah, it's a big question who actually owns the patient data. It's really the patient's data. So really the patient owns their own data. But if the data is stored in a doctor's office, in their EHR or their billing system, the data belongs to the practice. They're basically a custodian for the patient. Now, there's been a lot of issues out there. Or if I want to go in and I want to sign into a personal health record, I go through Microsoft or Google, and then Google's taking that information and storing it and then selling that data. That a patient logged in and was looking for something, looking for information on diabetes, or they're taking that data and they're now selling it to other organizations. There's been a number of lawsuits that have come out recently that's saying, no, that data belongs to the patient or belongs to the care provider, the hospital, the doctor's office. You cannot take that information and sell it to somebody else. So realistically, who owns the data? It's the patient's data. They own the data. The practice or the hospital can be the custodian of that data, but they cannot give that data to anybody else, and no one else can access that data. And that's off of the HIPAA regulations that came out, that basically all patient data should be confidential.
Excellent. I can also add to that when you look at what's going on these days with Apple Watches, with Fitbits and this and that, patients are able to contribute to their patient data more than ever before. I mean, smart companies, smart EHR companies understand that it really is up to the doctor to, okay anything the patient's adding. That's why in most patient portals, when patients are adding things like their allergies or family history, it has to go into some sort of a pending queue where their healthcare provider sees that and just says, sure, send it to the patient record, because we want to make sure that there is accountability on the provider's end where they're able to see it, and we're not just putting the patients fully in control of their actual EHR record. We want to keep the provider involved, but the point is that it's come to a point where just by wearing something like an Apple Watch, and I'm not promoting the Apple Watch, there's other smart watches, any one of these kind of watches, they have built-in pedometers, heart monitors. It's fascinating that without realizing it, all this stuff is actually even being tracked, and your device may know a lot more than you think it does about you, and it could be useful when you sit down with your doctor and they say, realistically, how much exercise do you get? How many miles a week do you walk? That stuff is being tracked without you even really realizing it. And it's important, I should add, that it's used for the right reasons. Unlike what Mark was saying earlier, how there was situations where some of the big tech companies are selling that data. We don't want to see that. We want it to be used for good. The RCM piece, I'm going to skip over because obviously initially Mark was going to jump in at this point, but he he graced us with that excellent presentation to lead. And any other questions here, please feel free to share them through that Q&A. I don't see any, so I think we can just wrap up a little early. It's 2:50 Eastern, so consider this a present of 10 minutes, I guess, that we'll give you for you to stand up and stretch before your next meeting. But thank you so much to Mark Anderson of the AC Group, who, again, I admire and respect. I think I saw you for the first time in 2002, speaking at a conference in Las Vegas. Just to add, I'll leave you with this story, and this is when I started in this space, and Mark laid out this picture of where healthcare was going, and he was so spot on. He said, he drew on the board, there's going to be, here's a little town, at the center you have a hospital, and everything in that town is flowing right to the middle, to the hospital. And sure enough, that's exactly what happened. And you know, he basically painted the picture of what was coming in the next 10 years. So, you know, he is the healthcare futurist, and Mark's been around for a long time and knows this business inside and out. We thank him for his contributions, as always. And thank you for joining us today. And we look forward to serving you in the near future.
And have a great weekend, everybody.
Yes,
Goodbye.
have a great weekend.